All right. So first we're going to be starting out by talking about amenorrhea. This is the absence of menstrual flow. Most of the time, if a woman is not having a period, it is indicative of an underlying medical condition or something else that is going on with her. Okay. Um, it is impacted by a lot of different things. So a woman can miss a period or not have a period for a while for a lot of different reasons. Some of the more common causes are any changes or major fluctuations in weight. So, if a woman has lost a significant amount of weight, or if a woman has gained a significant amount of weight in a short amount of time, that can sometimes cause amenorrhea or missed periods or um, infrequent periods. So, other things, if you have a patient who, let's say she's like 16, she has never had a period, but she's been involved in really competitive sports for her entire life. That is not something we immediately want to be concerned about because being extremely active, especially in your youth, can lead to amenorrhea or getting a period, a delayed period, or infrequent periods. Outflow, when it says outflow tract obstruction, that just means that there's something with from an anatomy standpoint that is altered in your patient that is not allowing for that menstrual blood to pass through the vaginal canal and the endometrial lining to be shed. So, for example, I had probably like one of the most interesting surgical cases that I've had was a patient who was complaining of pain with sex. She and her partner could not have sex. She was not having a period. They wanted to get pregnant, but she wasn't having any period at all. This had been going on for years and years and years. Um, so the provider thought that she had an intact hymen that was like blocking the vaginal opening, which can sometimes cause pain, sometimes can lead to infertility issues, things like that. So we went in to try and just like dissect away that hymen, just cut the hymen away. And it turns out that she had a fistula that had formed in her vagina that kind of diverted back into her musculature away from where her cervical opening was. So any menstrual blood was just being trapped and the body was reabsorbing it and it was being dissolved. But like she didn't actively have like an open vagina that led up to a cervix that went into a uterus. So that is what we mean by outflow tract obstruction. There's something going on from an anatomy standpoint that is limiting or prohibiting that blood from coming down for a woman from bleeding. Other things is if a woman has a giant tumor in her vaginal canal, that can cause an obstruction. And those are things that we can see typically with a speculum exam or an ultrasound, right? So that's an example of why someone might not be having a period. Polycystic ovarian syndrome, or PCOS, is a very common disorder that a lot of women experience when they have the like string of pearls on their ovaries. This can lead to excessive weight gain, abnormal hair growth, acne, uh, infertility issues, lots of things PCOS can cause. PCOS is also very common. These patients, it's very common for them not to have regular periods, for them to have infrequent, irregular periods. Thyroid disorders. If your patient has hypothyroidism, there's a very good chance they are not having a period or they're having irregular periods. Hyperthyroidism, you don't see that as much. It can happen, but with hypothyroidism, it is not uncommon for women not only to get their periods later in life, but to have infrequent periods. And oftentimes, thyroid disorders are mistaken for PCOS in women, especially if someone comes in saying that they haven't been able to conceive, saying that they're having irregular menstrual bleeding, they have excessive weight gain, hair loss. All of those things that are associated with hypothyroidism are also associated with PCOS. So it's often misdiagnosed or overlooked. So thyroid disorders can cause amenorrhea. Type 1 diabetes and drug abuse can also cause absence of periods. So, how do we assess for this and what do we do? If a patient comes in and says, I haven't had a period in 6 months, I'm pregnant, is that a positive? pregnancy sign? A missed period. No, let's take it back all the way to, I think, exam one. That is not a positive pregnancy. What is our positive signs of pregnancy?
Ultrasound.
Ultrasound. Oh,
Yep, you guys got it. An ultrasound. We need to be able to auscultate or visualize the fetal heart rate. That is the only way that we can positively say that, yes, you are pregnant. Okay. So what are we going to do? We cannot treat amenorrhea until we have identified the underlying cause. So we need to find the underlying medical condition or the underlying root to the problem. So we're going to get an extensive H&P on this patient. We're going to collect lab work, so CBC or analysis. We're going to do a TSH, check her thyroid function, potentially get a CT scan if we're concerned about an obstruction, like a tumor or something in the vaginal canal that is obstructing or in the uterus or something like that. Um, we need to obviously rule out pregnancy first or menopause, depending on the age of the woman. Um, ask them about their lifestyle habits. What is your exercise regimen? What is your nutritional status? How is your diet? What does it look like? And then once we find the cause, we treat it accordingly. Okay. If it's hypothyroidism, we give our patient levothyroxine, and most of the time they have regular periods after that. Okay. Um, this hypogonadotropic amenorrhea is a specific kind of amenorrhea that results from hypothalamic suppression. So, what causes this? Dramatic weight loss. So, eating disorders is going to cause this. Stress. If a woman is under extreme stress and she's having that suppression, she is going to start to not have a period. Okay. Strenuous exercise or mental illness. So, if a woman is anorexic, this can lead to this version kind of amenorrhea. If somebody is pushing their body, like they're training for an ultramarathon and they're not fueling properly and they're just kind of like winging it and just completely wearing themselves out, they run the risk of not having a period, of throwing off their cycle. All right. Next, we're going to talk about cyclic perimenstrual pain and dysmenorrhea. So, CPPD describes women's experience of discomfort with the menstrual cycle. So, these are the symptoms and fun side effects that go along with having a period. These can have a very significant impact on quality of life. They vary per person, they vary per woman. Some women have no period, have no pain with their period at all. They rarely have any type of side effects. Other women are completely debilitated. They can't get out of bed. They are down and out for the next week or so. Okay. So we need to understand the different kinds of dysmenorrhea and when they occur. So, dysmenorrhea in general just refers to pain during or before menstruation. So there's two different kinds and two different categories that we break this up into, primary and secondary. Our primary is associated with our ovulation. It's associated with our menstrual cycle. So research shows that primary dysmenorrhea has a biochemical basis and usually arises from the release of prostaglandins. So we know from exam 2 content that that release of prostaglandins is going to increase the frequency and amplitude of uterine contractions. Having a period is having contractions, right? It's just you're not delivering a baby, you're shedding your endometrial lining. So if those prostaglandins are being released, we're going to have a major hormonal fluctuation. We're going to experience a lot more uterine contractions that are painful during that menstrual cycle. Okay. Women are going to experience backache, weakness, sweats, GI symptoms, usually diarrhea, dizziness, and nausea. All the fun things that go along with having a period. Pain management for this, it can be pharmacological or non-pharmacological. So from a non-pharmacological standpoint, we're looking at heating pads, warm baths, light exercise, massages, aromatherapy, eating a whole pint of Ben and Jerry's, all those things. Okay, those are therapeutic. Your pharmacological is most likely NSAIDs. All right, so that's usually what we're using for menstrual pain. Our secondary source of dysmenorrhea comes from our pelvic pathology. So, what does that mean? That means this develops usually later in life because it's associated typically with underlying medical conditions such as endometriosis and pelvic inflammatory disease. So, most women do not get a diagnosis of endometriosis until they are trying to have a child and they are having problems with infertility, unfortunately. Endometriosis is one of the most misdiagnosed medical conditions for women, and it's something that is becoming more and more common that we see being treated now because women know how to advocate for themselves. They know how to say, "Hey, my pain that I experience with my menstrual cycle is not normal. I can't get up out of bed. I have to call off work. I'm constantly sick. I can't eat anything." Like if they're at that point, then they're urging their providers to do something more to explore what's going on with them. Okay, so with this, our treatment is removal of the underlying pathology. So, if a woman has endometriosis, our treatment is to go in and remove those extra cells that are growing outside of the uterus. That is going to relieve her pain. That is going to relieve the amount of bleeding that she encounters every month with her cycle, and overall improve her symptoms. With pelvic inflammatory disease, we need to remove or treat the underlying cause for this inflammatory response, whether that's an STD or an STI, prolonged yeast infection, or something going on like that. So we need to treat the underlying cause in order to treat this secondary form of dysmenorrhea. All right. Premenstrual syndrome or PMS. This occurs in 75% of women. It begins in the luteal phase of the menstrual cycle and it affects our quality of life. What is associated with PMS? Bloating, pelvic fullness, edema of lower extremities, breast tenderness, weight gain, behavior, or emotional changes. These are the things that occur leading up to your period that kind of give the woman an idea, this is going to be happening soon. Okay. These things are different for every woman. They are different from cycle to cycle. Not all women experience all of these things. Some never experience any of this. Some experience more than this. Okay. So we just need to talk with our patients and figure out where they stand with everything. Premenstrual dysphoric disorder is a mental health disorder that some women are diagnosed with, and it is PMS on steroids. Okay, it's like these women are experiencing not only premenstrual syndromes, but they're experiencing them in a somewhat manic capacity. I don't like to say manic because that's associated with other mental illnesses and disorders, but it is just PMS to the extreme. Okay. So it's the more severe variant. They have increased irritability, mood, and mood instability. They have to have and meet a certain criteria to receive a diagnosis. And usually this involves them following closely with either a therapist or counselor for about a year before they receive the diagnosis of PMDD is what the abbreviation is for that. All right, moving right along. Let's talk about endometriosis. So this is the growth of endometrial tissue outside of the uterus. So here in this picture, you see our uterus. You were used to having this endometrial lining just right here inside of the uterus. These growths on the fallopian tubes, on the ovaries, into the musculature. Um, this is endometrial cells, okay, growing outside of the uterus. Um, so one thing that we need to know about endometriosis is that this tissue, okay, that's growing outside of the uterus, it contains uterine glands. So as a result, it's going to respond to cyclic hormonal changes. So in the same way that our uterine endometrium does, um, these cells are going to fluctuate, they're going to grow, they're going to expand during a cycle, okay? So the tissue is going to grow during the proliferative and secretory phases of the cycle, during or immediately after menstruation, after we have our period. The tissue is going to bleed, resulting in an inflammatory response with fibrosis and adhesions to adjacent organs, it cannot be comfortable. I personally do not have endometriosis, but I've had a lot of patients that have had endometriosis and they say that it is awful. So, These cells are growing, they're changing with alongside the cycle. Um, so that can be very painful for these women, okay? Signs and symptoms are going to vary, but most common are pelvic pain, dysmenorrhea, and dyspareunia, which is pain whenever they're having sex. Um, the biggest thing that flags providers to try and diagnose or try and explore this more is if a patient is not getting pregnant. Okay, infertility can occur with endometriosis, so we need to be careful. Another thing that can happen with endometriosis is they are at an increased risk for ectopic pregnancies. Why do we think that is? If we see where all these cells are growing, why could we suspect that they could have an ectopic pregnancy?
'Cause they get stuck and they can't get past the fallopian tubes.
Yeah, so if you have an excessive amount of cellular growth on the fallopian tube, it could potentially lead to either obstruction, partial obstruction. It can also lead to scar tissue, scarring. So if the fallopian tubes have an abundance of scar tissue, they're not going to be as flexible, they're not going to be as pliable for that ovum, that fertilized egg, to make its way down through the fallopian tube into the uterus and successfully implant into the endometrial lining, right? So these patients have an increased risk of that, and that is another reason why they have an increased risk of infertility because of the scar tissue, because of the damage that these cells can cause, okay? Treatment for this, NSAIDs, unless we're trying to get pregnant, then we have to be cautious, right? We shouldn't be taking Motrin or anything like that whenever we're trying to conceive. The biggest one, the most common thing that women will do if they want to avoid a surgical procedure, are hormone suppressants. So these medications, Lupron and Danazol, they are going to suppress estrogen production, which is therefore going to suppress endometrial lesion growth. If we have less estrogen, we have less hormonal fluctuation, we have less endometrial tissue developing. Okay. Um, and then last resort is surgical intervention. This can span from our general, like laparoscopic removal of endometrial tissue to sometimes a total hysterectomy, depending on how severe the endometriosis is and whether or not the woman wants a child. Okay. If the woman is wanting to conceive, we can go in and remove some endometriosis, and sometimes that woman will get pregnant like the next month. Okay. That's all that needed to happen was removal of those cells. Other times, if a woman is at the point in her life where she just does not want to have children, she just wants to have the hysterectomy, then that's something we can do with an informed consent from the patient. Alterations in cyclic bleeding. You guys need to know these definitions and you need to know what they mean. So oligomenorrhea is infrequent menstruation. Hypomenorrhea is scanty at normal intervals, so like bleeding, light bleeding regularly. Menorrhagia is excessive bleeding that occurs at a time other than our menstrual cycle. And then metrorrhagia is heavy menstrual bleeding. Okay. So, what are some things that can cause abnormal uterine bleeding? Pregnancy can cause abnormal uterine bleeding. Implantation bleeding that happens within the first couple of weeks of the pregnancy. Whenever a woman may have some light spotting, that can indicate that the ovum successfully implanted into the endometrial layer. They can have bleeding throughout their pregnancy if they have a placenta previa. They can have bleeding throughout their pregnancy if they have a sensitive cervix or a highly vascular cervix that can cause bleeds, like during a bowel movement or during physical exercise or sex. Um, Lots of things during pregnancy can cause bleeds. Reproductive tract infections, so our STDs, STIs. Benign anatomic abnormalities. So if a woman is born with two vaginas and two uteruses, or one vagina and two uteruses, sometimes that can cause abnormal uterine bleeding. Or even just like normal scar tissue or fibroids that can cause bleeding. Neoplasms or malignant lesions, those can cause bleeds. Trauma. So, like if a woman was in an accident, if she's a victim of rape or sexual assault, that can cause some bleeding. Other things are systemic conditions like hypothyroidism, liver disease, diabetes, and other endocrine disorders. All right, let's talk about infections quick. For our infections, we've talked about these throughout the semester. Okay, these aren't anything new that we should be seeing for the first time, but they do play a role in abnormal uterine bleeds and infertility. Okay, so with chlamydia, if we have an infant that is born to a mom who has an active chlamydia infection, half of these infants will have conjunctivitis or pneumonia after prenatal exposure. Okay, so our babies we run the risk of them having conjunctivitis or pneumonia. Gonorrhea, that can give us some complications perinatally, so premature rupture of membranes, preterm birth, neonatal and maternal sepsis. Our syphilis here can cause pelvic inflammatory disease, which is the most frequent infection for women. So if a patient has reoccurring PID or PID that is not resolved, we probably should test her for other STDs and treat the underlying STD that could be causing this inflammatory disorder. Patients with syphilis also have an increased risk for ectopics, infertility, and they're also going to be in chronic pain. Okay, they're going to be pretty uncomfortable. HPV. So the most well-known strand of HPV is the kind where a woman presents with genital warts. That is not the only strand of HPV. There are hundreds of types of HPV infection. Several can cause genital cancers. Not all of them cause genital warts. Sometimes women will go their entire life um, without knowing they have HPV. They don't have any signs or symptoms or any type of abnormalities. But this is why we encourage pap smears because we want to detect if a woman has HPV because it puts her at a risk for genital cancers. Um, so, like I said, we're going to do that badge exam and a pap. Prevention, there's a vaccine, the HPV vaccine. So we need to get that on board before exposure. So usually it's given in 2 doses, ages between ages 9 and 26. Boys and girls should both be receiving the HPV vaccine. Okay, this is not just for one or the other. And then herpes. If a mom who is pregnant has herpes simplex virus, type 2, so the genital herpes simplex, they need to be on suppression therapy. So it's typically antiviral medications. I think the most common one that I see women prescribed with is acyclovir. This is a suppression medication to prevent them from having outbreaks during the end of their pregnancy. Because if a woman comes in labor and we do a speculum exam, she has a history of HSV, and we see an active sore or lesion, she immediately has to have a C-section. Okay. This HSV infection, not H, yeah, HSV infection is extremely deadly to newborn babies. Babies, if they get HSV, it is a big deal, okay? This also is kind of scary because HSV infection in a newborn it does not automatically like clinically present itself in like the first 24 hours. Like HSV infection can occur up to like, I think it's like 6 weeks after delivery. So it's a long time. So we need to be really thorough in monitoring these patients when they come in to ensure that they're not putting the infant or newborn at risk. Finally, we're going to talk about like hepatitis A, B, C, and HIV. So hepatitis B is the most threatening to a newborn, so we need to practice good hand washing and administer the vaccine. The first dose can be offered at delivery or as close to delivery as possible. HIV is transmitted via bodily fluids, so that means that moms with HIV cannot breastfeed their baby, okay? It passes through the membrane layer, and the babies run the risk of contracting or getting sick themselves, okay? Um, these patients need to be on zidovudine or antiretroviral medication during pregnancy to reduce their viral load. Um, we're also going to be scheduling patients with HIV a C-section at 38 weeks if the viral load is more than 1,000 copies per ml. And then that medication is going to be administered to them during labor, and then giving the babies oral medication for about 6 weeks. If a patient If a newborn is born to a mom with an active hepatitis or HIV infection, they should be bathed like immediately just to reduce contamination or the baby from getting like sick or anything like that. Okay, these babies should be bathed like right away. Other infections that you guys have heard, bacterial vaginosis. This is the most common vaginal infection. It's associated by a fishy odor with profuse discharge. Women who have untreated bacterial vaginosis in labor can sometimes encounter preterm labor or postpartum endometriosis. So we need to make sure we're assessing for it and treating it. Yeast infections are very common. This is a fungal infection caused by overgrowth of yeast. Signs and symptoms are itching, pain with sex, pelvic soreness, and thick white vaginal discharge. Trichomoniasis is char- characterized by that mucopurulent malodorous discharge and pruritus. So mucopurulent is a thick, opaque, colored discharge. Okay. Treatment for trich is antibiotics for both mom and the sexual partner. Now there's a lot of research coming out saying that anytime a patient is diagnosed with an STD, STI, some type of bacterial infection, their sexual partner or partners should also be treated themselves to prevent reinfection. Okay, which makes sense to me. I don't know why this wasn't something that we were doing like a long time ago, but they're trying to incorporate this now. Group B strep, GBS, we've talked about this a lot in this class. So GBS is a normal flora associated with poor pregnancy outcomes. Babies, if they get GBS, it can be life-threatening. Um, we need to screen moms at 35 to 37 weeks of gestation. That's when we do the swab in the vagina and go down to the rectum and swab the rectum. We send that out for testing. If they have higher than normal viral loads of the GBS infection, they have to have antibiotics during labor. The antibiotic that we most likely will prescribe them is penicillin G. Any questions so far? All right. So, fibrocystic disease. This is a condition of the breast that is benign. This is sometimes what happens when a woman will have like lumpiness in her breast tissue with or without tenderness. Um, it's just they have very dense breast tissue. That's the best way to put it. These women who have this kind of disease just have very, very dense breast tissue that can sometimes feel lumpy. It doesn't necessarily mean they have cancer, but what it does mean is that it makes detecting cancer much more difficult because it's hard to differentiate between just a normal like cyst or mass and then a cancerous lump, right? So these lumps that these women have in their breast tissue are going to fluctuate and are usually movable. They may have some green or dark brown discharge from the nipple. Usually it's worse before they get their period. They experience swelling, tenderness, pain. The treatment is usually non-invasive. We don't really go in and do surgery on this or anything like that. Um, Birth control pills or hormone therapy can help with this. Over-the-counter pain relievers, supportive bras, warm or cold compresses can help. Also, like limiting caffeine intake and converting to a low-fat diet will help because high-fat diets and excessive caffeine intake can increase the density of your breast tissue. So, we encourage women who have this to cut back on their caffeine and incorporate a low-fat diet. All right. All right, moving on. We're going to talk about infertility. This affects 1 in 4 couples. Okay. Typically, I shouldn't say typically, but it's correlated with increased age. So the older a couple is when they are trying to conceive, the higher risk they are for experiencing or struggling with infertility. Okay. A couple or a mom is not diagnosed with infertility issues until they have been trying to conceive for at least 1 whole year. Okay. So that is a year off of birth control. That's a year of tracking your ovulation. That's a year of actively trying to conceive. Um, and if a pregnancy is not achieved within that year, then we're going to start doing diagnostic testing and going down the path of trying to figure out why they are not getting pregnant. So, what we have to do is identify and treat the cause. Sometimes the hardest part about infertility, and this is like your patients, if you ever have a patient who struggled with this, or if you know someone who struggled with this before in your life, the hardest part about it is most of the time infertility does not have a cause, and that the hardest part of it is whenever they can't find an underlying cause as to why a woman isn't getting pregnant. So we're not able to treat it and we're not able to help them conceive. Okay. Um, so as you can imagine, this is really hard for couples. This is really hard for moms or women who are wanting to be pregnant. So we need to be supportive and be there for the patient in the best way that we can. Okay. Whenever we go down this road of infertility in our assessment, we assess both the male and the female partner for what could potentially be causing the infertility issues. So, for a woman, we're going to examine structural versus other factors. Is this an anatomy thing? Is this a hormone issue? Or is she just simply not ovulating? Does she have PCOS? Does she have endometriosis? What does her underlying medical history look like? Uterus shape and size plays a major role in fertility for a woman. When it comes to the man, most of the time they have infertility can be caused by low levels of testosterone or low levels of sperm in each ejaculatory cycle. So we have to observe that as well, okay, and test both partners. Once we have determined what the underlying cause of the infertility is, then we can proceed with treatment. Okay, so treatment can be assisted reproductive therapy like IVF, donor eggs, surrogacy, and adoption. Okay, the most common thing that we do for infertility is prescribe specific medications. These meds are metformin and Clomid. These are follicle stimulating medications, so they induce ovulation. The biggest thing with these medications is multiple pregnancies, multiple gestations, because if you're stimulating ovulation, you run the risk of having multiple eggs released at once, and that can lead to lots of pregnancies, a multiple gestation pregnancy, okay? Like I said, we're providing emotional support. People that go through IVF, this is like one of the most taxing things that people can go through, not only from an emotional standpoint, but also from a financial standpoint. People spend hundreds and thousands of dollars on infertility treatment. So, as a nurse, we need to be sympathetic to that. We need to be sympathetic to our patients and be there for them for whatever they decide and for however long they want to continue to try to conceive, okay? Here's a picture that kind of displays different shapes of uteruses that can lead to infertility issues. If a woman has an odd anatomy with her uterus, that does not necessarily mean that she can never get pregnant. It just means it's going to be harder, right? And this might be a patient who, if she has a specific type of uterus that is not conducive for carrying a baby, we might need to physically go in and place the fertilized egg into her uterus, right? If it's appropriate. All right, contraception, the intentional prevention of pregnancy or family planning. I guess nearly half of all U.S. pregnancies are unplanned. There's a lot of different types of contraceptive methods. The first we'll talk about is coitus interruptus or the withdrawal method, which can be effective and also cannot sometimes not be effective. So we always want to educate patients that if they're using this method, they should also be exploring alternative means of contraception to be safer if they're really trying to avoid a pregnancy. Fertility awareness methods. This just means like tracking a woman's cycle. So calendar rhythm, abstaining from sex during the ovulatory period. Sometimes if a woman measures her basal body temperature and compares it every day, she gets an idea of if she's ovulating or not. We know sperm can live in a woman's body for up to 5 days. The egg lives 24 to 48 hours after it is released, so there's a larger window of time where fertilization can occur. You have to avoid unprotected intercourse several days before and 3 days after ovulation in order to successfully prevent a pregnancy. Another form of contraception is the IUD. An IUD is a plastic device that goes up and sits at the opening of the cervix. It prevents pregnancies from a small release of locally acting hormones. It does not protect from STIs because it's not a barrier, right? This has to be placed and removed by a doctor. There are multiple different kinds of IUDs. There's the plastic hormonal IUDs, and then there's a copper IUD, which is bigger. The copper IUD is enticing to patients because it doesn't have hormones in it. Okay. However, the copper IUD, it's bigger and it can get moved a lot easier, and it sometimes can implant and embed itself in the uterus or other places that we don't want it to be. Okay, so we need to educate these patients on the differences between the two types of IUDs so they can make a decision on which is better for them. Barrier methods are like your diaphragms or your condoms. Um, Hormonal is your birth control pills. Also, like Plan B would be a hormonal emergency contraception. The biggest thing with Plan B that we need to educate our patients on is that it is weight based. Okay, so if a woman is larger, she may need to take. Why did I just pin? I don't know what that means. Um, she may need to take more than one Plan B. Okay. Contraindications to birth control pills or any type of hormonal contraception would be any type of cardiovascular disease, if the woman is breastfeeding, if she's had a history of clots or blood clots, if she's a smoker, or diabetes with some other type of underlying vascular disease. Okay. And then, of course, if they are really wanting to prevent a pregnancy, and then we can look into tubal ligation or into a vasectomy. Okay, signs of complications with oral contraception. So this is some things that women can experience as a result of birth control pills or hormonal contraception. So they can experience abdominal pain, chest pain, shortness of breath, headaches, eye problems, and severe leg pain. Here I have a picture for you guys of a diaphragm with the spermicide being placed in there, and it goes it right up and acts as a barrier. Okay. This is the hormonal IUD and then the copper IUD. So, when we do like a sterilization for the vasectomies, we're cutting or cauterizing the vas deferens. In a female, when we're doing like a salpingectomy or a tubal ligation, we're going to cauterize and remove the fallopian tube. Is typically how it's done now. Okay, there are many ways that providers will do it. Sometimes they'll put these like ties on the end of them. What I see a lot of providers do is just completely remove the tube, leave the ovary, leave the uterus, but remove the fallopian tubes. Okay. Um, some old school physicians still use Filshie clips, which are like plastic clips that you'll put on the fallopian tubes. Um, this obviously we are trying to steer away from because it's plastic and that is in a patient's body for the rest of their life. So we want to try and avoid that. All right. Last, we're going to talk about abortion. We're also going to talk about fetal loss and neonatal death. So, with abortion, we are going to talk about elective therapeutic abortions. So, this is the purposeful interruption of pregnancy before 20 weeks of gestation. This can be elective, it's a patient's choice. For whatever reason, they just have chosen to discontinue the pregnancy to not carry the baby to term. It also can be for a therapeutic reason. So the baby has a genetic disorder that is ultimately going to lead to their demise at delivery. The mom might have an underlying medical condition that does not allow her to safely carry a pregnancy, or she is a victim of rape or domestic assault or human trafficking, one of those things. As we know, abortion is a very hot topic in the United States. This is not a politics class, so we're not going to go there. Everyone is entitled to their own opinion, but as a bedside nurse, it is always our role to provide unbiased, unjudgmental, holistic, well-rounded care to our patients, regardless of the situation or regardless of what's going on. That being said, this is one of the only things that A1 will support a nurse's right to choose to participate. So, what does that mean? That means that if you are somebody who has very, very strong opinions regarding elective abortions, you are allowed to legally ask for a different nurse to take care of that patient. Okay. So you do have a choice in that and whether or not you wish to be the primary nurse in these types of cases. If you are a patient's primary nurse during an abortion, whether it's elective, therapeutic, medical, whatever it is, we need to keep the patient at the front of our mind and make sure that they are the priority and make sure that we are providing the best care that we possibly can for them in a non-judgmental way. Okay? So, with abortions, we know that having an abortion in the first trimester is the safest because the fetus has not developed to a point where the size is dangerous and can lead to physical problems for the mom. So, medically speaking, what providers will typically do is administer Cytotec or methotrexate. Methotrexate is going to dissolve those developing fetal cells. Cytotec is going to cause uterine contractions that expel the endometrial lining of these uterus. Okay, common complications that we're going to see in this with first trimester abortion would be infection. Okay, huge risk for infection. Retained products that can happen even this early on, and then excessive bleeding. Women can still have hemorrhages with these. It doesn't matter really how early they are or how big the fetal cells are or how big the fetus is. They can still have excessive bleeding. Okay. In the second trimester, if we are having an abortion or if a patient is having an abortion, elective or therapeutic in the second trimester, they are at an increased risk because that fetus is more developed. The fetus has now developed bones. They have a more bony structure. They can be a little bit, they're definitely going to be a bit bigger. So the safest approach to this is a surgery, a dilation evacuation. Okay. Something we need to educate our patients on is that if they do choose to do this, that is their choice, whatever they decide to choose. It can have possible long-term effects on the cervix. And this also can sometimes lead to scar tissue buildup and problems with fertility later in life. Okay. Other things that we need to talk about when we're talking about these kind of patients and we're talking about abortion therapy. What does this patient's support system look like? Okay, if this patient is getting an elective abortion, they are going to have family members and friends who may or may not know about this decision and who may or may not agree and be supportive of this decision with them. So, as their bedside nurse, you are going to be a big support system for them throughout this process. You're going to be a reference for them, and you're going to be somebody that they should be able to trust and talk to. Is this person a victim of human trafficking? If they are, we are mandatory reporters and we have a responsibility to make sure that they are safe and they have other options and that they have somewhere safe to go after their procedure. Okay. If a patient expresses interest, we can give them referrals to adoption agencies or like pregnancy resource centers. Okay. That being said, if a patient comes in and is scheduled for an abortion, it's not your job to stand there and like preach to them about adoption or give them paperwork and give them resources if they're not asking you for them or they don't show any interest in that. Okay, we have to be respectful of what these patients are wanting. Um, and usually these resources are reserved to be talked if the patient is asking about it. Um, we're always going to encourage post-abortion counseling. Usually it's because they can have long-term depression or guilt. Some patients can experience that whenever they go through this kind of a procedure. So we have them in counseling. We encourage them to be seeing somebody regularly over the next couple of months. All right, just a little bit left. We're going to talk quick here about fetal loss and neonatal death. So, fetal death is described and defined as after 20 weeks of gestation and before birth, when a newborn passes with absence of signs of life at birth. Okay, most of the time, what will happen is it's diagnosed in the office, like they can't find a newborn heartbeat. A mom will sometimes come in with decreased fetal movement, and we don't find a heartbeat, that kind of stuff. So the baby has already passed in utero. A neonatal death is a baby that passes within the first 28 days of life. Okay. This is the infant mortality is the greatest in the neonatal period. So in that first 28 days. So that's why we educate our patients extensively with their going home instructions, especially with safe sleep to prevent things like SIDS, stuff like that. These are never easy cases or patients to take care of, okay? Because anytime you deal with death, anytime you're dealing with loss, it's really, really hard. When you're dealing with loss of a newborn or loss of a pregnancy, um, you're facilitating the grief of the parents, and you're also facilitating like taking care of the newborn or the baby themselves, right? So, I've helped take care of miscarriages as early as 9 weeks. And I've also helped deliver stillborns at like 42 weeks of gestation. Okay. So it is never easy, no matter what the gestational age, no matter where this mom is in her pregnancy. This is something that's really challenging. And it's hard to understand how to deal with it as a bedside nurse. But what we need to know is we need to know what the parents' wishes are, right? So we need to be respectful of that. Sometimes parents want to hold the newborn, they want to be alone with the newborn, they want to snuggle, be skin to skin with the newborn. Other times, moms are like, I don't want to see the baby, I can't. And it's okay. There's no right or wrong answer, there's no wrong way to handle this situation. So, we're going to focus on providing end of life care. Organ donation is something that we can do, especially in like a late second, third trimester infant, but it's something that we're going to discuss with the parent before the baby is delivered. Okay, because after that baby is born, we are going to make that room as quiet, um, peaceful as possible. We're not going to be going in there and asking them about organ donation. This is a conversation you need to have in the admission questions, okay? We are going to obviously have a space that facilitates grieving. So, um, give them the opportunity to hold their baby. You can let them give the baby a bath. You can have them dress the baby. We also will offer to give them these like tangible mementos. So I'd usually would do like handprints and footprints. You can also offer to like take like pictures of the baby's hands that they can have to take home. Usually they get like a big forget me not box that has like mementos and stepping stones and like prayer shawls and blankets and stuff in it. Okay. If the patient wants their baby baptized, we can call the chaplain, the hospital chaplain, in to come and see the baby and give like a prayer over the baby. Um, and then also, like, we need to make sure that our caregivers are taken care of, okay? These situations are terrible, and you need to make sure whenever you are in anything like this in your nursing careers, which I'm sure you guys will be if you have not already, you're taking care of yourself and you're making sure that you're doing things for you as well to make sure that you can help get through this as well. All right, and then this last slide here goes through the Swanson's caring theory. This focuses on teaching and healing during pregnancy, and it lists the 5 healing processes necessary to provide closure. So just familiarize yourselves with these 5 um, healing processes, okay? And that's, I think, all we have. I know that the last like bit of that PowerPoint is pretty heavy, especially after taking an exam. But you guys are all troopers, okay? If anyone has any questions, feel free to stay after class, but we are at the end of class time, so I hope you guys have a great rest of your week. Exam grades will be posted on Friday, but you guys should all go into it feeling pretty good about them, okay?
Okay, thank you.
You're welcome.